Now we'll move to the interesting cases segment. Who's going to go first? Is it Dr. Lee or Dr. Carr? So Saibal, it's your case. Yeah.
Is it there?
Yeah. Oops. Oh, sorry, it's on. So we're going to show an interesting case, and I thought that Dr. Natali is here, and Vijay is here. We should show this case. So he's a 49-year-old gentleman who did have catheter-based AFib ablations in the pulmonary vein 3 times since 2009. I don't know whether, Dr. Natali, you did the procedure. Presumably you didn't. And his last ablation was in May 2012. And his paroxysmal history, he has long-standing paroxysmal AFib for 3 years, recurrent AFib following 2 ablation procedures, which led him to have the third. Now, after his third procedure, he did complain of some shortness of breath for about 4 months. And we didn't know what it was. But the person who was taking care of him actually appropriately did a CT scan of the chest and detected that he had pulmonary vein stenosis of the left pulmonary vein. And to be more precise, I unfortunately don't have the CT image here, which is there. The left lower pulmonary vein was completely occluded, and the left upper pulmonary vein was 90%.
Wow. So there was no residual flow through the left inferior.
So left inferior was 0, and the left upper was 90%.
So what? Well, this is by CT because many years ago, when this was certainly a more frequent problem, we saw that when by CT you had complete occlusion, almost 80% of the time you can actually pass a wire and dilate. So the complete occlusion by CT is not something that should sort of deter an attempt at dilatation. Because
so a CT total occlusion may not be a complete occlusion. Yes. There could be a chance. Mm-hmm. And the 90% was there. So we did, so the question is, and then we also did a VQ scan of the patient. And the ventilation perfusion scan of the lung showed decreased perfusion to the lungs.
A significant shift of the counts.
Right.
Perfect.
So based on that, I didn't have much of an experience in dealing with this patient, so I said, I thought that there is a clear mismatch, and there is a decrease in perfusion. I thought that it's reasonable to try to open this. Is that a reasonable approach?
So, yeah, well, so usually you see a mismatch as when you get to above 70% narrowing. Above 70%, you start seeing a mismatch. So obviously, when you have more than that, you should probably consider dilatation.
And especially with a 90%.
The only problem with this guy, because it's not clear if he developed this with the ablation in 2006. Unfortunately, it's possible that this tissue, especially when the occluded vein, it can be completely, unless you develop some collaterals, which by CT scan you're not going to see, but his lung tissue could be completely dead. And so even if you have an optimal angiographic results, you might not get any sort of improvement. So that's one of the reasons why we try to encourage people, although I still try to do a CT scan at 3 months because what you just reported is actually something that we published in Annals probably in the early 2000s, showing that especially a single pulmonary vein with severe stenosis, 80% of the time, has no symptom. But in California especially, the insurance will not pay for a follow-up CT unless the patient has symptoms, which is completely against the published data. They pay for the pre-procedure CT, which has never been proven to improve outcome. There's no study showing that improve outcome. They pay for that. But the post-CT, they will not pay unless the patient has symptom, although there are data published showing that if you have a single pulmonary vein with severe stenosis, 80% of the time you have no symptoms.
So before I go into the case, I did actually have a patient where I did a Watchman device. And while doing the TEE, I found that the left upper pulmonary vein was stenosed. And then I did a CT of that, and this is a different patient. And the left lower and the rights were normal. And then I discussed it, and most people said, leave it alone. Was it the right thing to do?
If it was a single vein.
Single upper vein.
Yeah, a single vein, patient asymptomatic is not going to make a difference in the patient. So, people worry.
If there was a shift in count, and if there is a novice compromise
yes, then
in diffusion.
But
I did a VQ scan. I did a VQ scan of the CT. 3 veins were normal.
Yeah.
The left upper was stenosed, but not 100%.
Yeah.
It was 80%. And so I was told that it's okay to leave
Yeah,
it.
it is. You know, in the past, we used to propose dilatation above 70%, but we have cases of complete occlusion that we follow, and usually the symptoms tend to improve. With a single vein, nobody develop hyperpulmonary hypertension, but zero. The people that develop pulmonary hypertension, they need at least 2 or 3 veins with stenosis. Otherwise, you will never. So for a single vein, you will never develop pulmonary hypertension. So but you know, I mean, if you can save the tissue but you have to intervene early, because if you wait a year, that might be too late. Yeah.
So anyway, this is, you can see clearly the lung scan. See that? You can see the left lung, that's the posterior view, is decreased. So there's actually very little flow of the left lung. So I thought it was the right thing to do, to attempt. So the question was the strategy. So our aim was to attempt to first try to open the completely occluded left lower vein. And then try the placement of and then still try to open the left upper pulmonary vein too. And we decided to go transeptal across, and then go with general anesthesia.
Why did you choose to go with the left lower first, Saibal?
I thought that we have less to lose because it's completely occluded. At least try to open that first. You see, the reason why I wanted to do that is because let's say this was 100% occluded, and now if I do something bad to the upper one, and there's a stent thrombosis, now he's completely lost his left lung. So I said my real aim should be first open the occluded one first, because I bet you there's collateral supplying the lower one. And if I can save that, then it's safer to open the upper one. So that's the reason why I did it. Is that reasonable too?
Yeah.
Okay.
Did you do it staged, or did you?
No, I didn't know what's going to happen. So I just went in with hope. It was just a hunting game there. So I just want to show you, this is a catheter. I use a transeptal catheter. I use the Agilis, right? Because I thought the Agilis would help me directly. And then this is the multi-purpose catheter in the left upper pulmonary vein. And this is the angiogram now. So you can see over here clearly, you see the stenosis? You can actually see a tight stenosis just at the ostium where it goes into the left atrium. And you can see the flow is almost stagnating. And you can also see these little collaterals there. See that? Yeah. So there's actually collateral. So I thought the stenosis was very significant. And then what I did was I moved this catheter with the Agilis catheter into the left lower vein. Unfortunately, I don't have an angiogram to show you the stump. And so I said, okay, this is going to be hard to cross, but I didn't know what Natalie just told me. It's very nice. And actually, it was not that difficult to cross, and I actually crossed it. So soft wire, and the wire went through. So then I decided to do a balloon dilatation of the vein, and the reason why I chose about 6 to 8 millimeters is I saw that the vein, normally the veins at this time are like 20 millimeters, but when I saw it narrowed from the CT, it was about 8. So I decided to use a small balloon, and everything was good, and so we did a balloon angioplasty, and it was quite a good result. And then about 6 minutes later, the anesthesia said that the blood pressure is 60. Okay, so I said, okay, blood pressure is 60, let's focus on why the blood pressure is 60. And then this is the echo that she's showing me. So that's the ventricle, and that's a large pericardial effusion. So my first thought process is, okay, I've obviously done a transeptal problem. I did a transeptal puncture, and I probably hit the posterior wall, or, I must have done something wrong because I gave heparin and I did a transeptal. This is a left atrial wall, so I said, okay, let's get a pericardiocentesis done. So we started doing a pericardiocentesis, and then I reversed the heparin, and so we drew out and normally what I do is I draw the blood and give the blood back. So I drew about 500 cc of blood, and I draw blood and give it back, and I drew blood and give it back, and it would just continue. Because normally I found if it's a atrial puncture tear, if you're correct, most of the time if you continuously aspirate and you reverse the heparin, it always stops. Because it's a low.
Unless it's really a bigger tear.
Unless it's a bigger tear, right?
Yeah.
Unless it's a bigger tear, most of the time, if I'm correct, most of the time you can.
It's a transeptal related puncture, yeah.
Last 12 years, I've never had anybody go to surgery.
Right. So now I had drawn 600 cc, and basically what I did, I had a fellow with me, 2 interventions fellows. I said, you keep drawing blood and giving it back. One guy was giving blood. I said, let me think about the whole thing.
But Saibal, how much of blood did you give? How much did you auto transfuse?
So
If you overdo that,
yes,
you get this DIC.
DIC, right. I know. So that was the stage. So I actually drew now 600 to 700 cc of blood. And this time I called the cardiac surgeon and I said, what am I going to do? And usually by 800, 900 cc, now I had drawn 1 liter of blood. And and what would happen is I would pull the blood out and you could see there's no effusion and you wait for about a few minutes and then you can see it's filling up again. So by then the two surgeons that came in the room, there were 10 people in the room, they said, Saibal, sometimes you got to say, no, you got to defeat, it's okay, accept it, come on, we'll take him to surgery, he's very stable now.
How many hours?
This is about 30 minutes.
30 minutes.
Yeah.
So,
35 minutes for what would you do?
so every hour you are bleeding more than 500 cc's an hour. Is that what was happening?
So,
Yeah, this is totally
so
fine.
what you didn't do there
I would-
is, did you shoot the venogram of that left inferior? What happened to the left inferior?
Okay. So then we called DJ and he said, shoot the pulmonary vein. So I called him and so, and I was like an idiot, I didn't listen to him. So now I did. So the question is, what do we do? Immediate pericardial resected, removed 1 liter, auto-transfuse the blood, stabilized, what next? And then I just decided to do an angiogram and say, wait a second, and this is what you can see.
Oh, yeah.
Oh, my God.
So you can see what the thing is. Now, I thought of this, but I never even thought it would happen because I said, look, it's in the pulmonary vein. Why should the pulmonary vein communicate with the pericardium? But the reason is that obviously this was at the ostium where it enters into the pericardial sac, and you can see that there's a clear tear and there's a blood just gushing out, and you can see of this blush. This is actually all the collateral from the previous vein. So this is now 1 liter of blood. I've shown this picture, and then the surgeon was there. He said, Saibal, okay, now we know the thing. Now the problem, the patient is stable. Now you've got a pericardial catheter in. The blood pressure's gone up. You've given the blood back. Now we should go for surgery. So, but I didn't want to give up.
So
My ego was hurt.
with the balloon.
So I said, what do we do now? So let's see what the options we had. What do we do next? We call a cardiac surgeon. The next option, we can pray.
Yeah, you sure should, right?
That should be the first.
That's all it's
Sure,
worth.
sure, yeah.
That's all it's worth.
Okay. So pray, everyone is agreed with, right? Cardiac surgeon consult, how many people agree with that? I think that's reasonable. Everyone, so two out of two I was right. Consider putting a covered stent in the pulmonary vein. How about that option?
I would
A stent with a covering.
Yeah?
Do
I
you
would do
have
that.
one?
Yeah, why not?
Yeah, we have an atrial tank. And then next one is all of the above. So I think we thought that all of the above, because we said prayer, of course we have to pray. We have to call a surgeon. But I said, let me try putting a covered stent, because I didn't want to give up. I remember the guy said, Saibal, stop, please, come on, let's take the surgery. So I said, give me just one chance. So I took a 6 millimeter by 18 covered stent. Stent is, I don't have a picture of the covered stent. Basically, it's a stent covered with a material called PET. And it's got 2 layers of stents, and inside that is the covering, right? So you can just take the balloon up. So we went there, and this is the covered stent being placed. And this is the angiogram after that. This is the next angiogram. And you can see that it's completely patent, and it's completely sealed the hole. So we said great. And now we dropped, and there's not a single blood transfusion, and the pericardial centesis is dry, and so it completely stopped with that. And so we said, okay, great. So he said, great. Everyone was like clapping, that's awesome. So then we said, what do we do now?
I think we're the prayers.
Huh?
The prayer got you the time.
prayer got it right time.
The prayer.
So should we now walk out of this case or not? What should we do now?
Yeah.
Okay, so everyone said, okay, come on, Saibal, you stop it, you've done a good job, stop it. I said, no, wait a second. He has a stenosis up there, 80% stenosis, and we have a pericardial catheter in place. If he ruptures again, we have a pericardial catheter in place.
And also
Why
there's
not-
a surgeon on standby
There's
too.
a surgeon on standby. So why not fix that? So we said, forget it, we just fix that too. So we do further expand the stent, reverse the hemorrhage, send the patient, or proceed towards stenting of the left upper vein. So most people said, stop, you reverse the heparin, remove all your catheters, send it to the ICU, you haven't killed the patient, it's great. And I said, okay, but I said, why not the upper one? So we
you
went
get
there.
more heparin.
So we gave a little bit more heparin, we watched the patient, and then we put a covered stent in. Now this I put a 12 millimeter covered stent, but just when covered, and it's completely normal flow now. See that? It's good flow, and no perforation. And then we did a lower injection after this, And we re-expanded that stent again with a 10-millimeter balloon, and the patient did well. The pericardial catheter, 2 days stay in the hospital, no blood transfusions required, discharged with a hemoglobin of 12. No recrimination of pericardial effusion. Patient has had a pericardial rub the next day, a very severe pericardial rub, which lasted for a week. And then he actually got admitted for pericarditis for a week later, and now he's come for follow-up after 8 months, and his perfusion is normalized in the left lung.
Well, I will say one thing, Saibal. You're great, but you're crazy. And especially, I mean, I would have said you had a great result on the left inferior. You could always brought it back, right? So, but again, I mean, it's your comfort level to withstand the pressure there. So, nicely done. Great job.
Thank you.
Saibal, how do you follow them up? I mean, it's high restenosis, right? Is that right for these?
No, I looked at the data. The atrium stent, the restenosis rate of the atrium stent is no higher than a regular stent. And plus, actually, there's data to show that the atrium stent in the iliac position is actually lower. There's nothing in the pulmonary vein, but it's lower than. And then what do you do with these patients? Give them aspirin, give them Plavix. So I actually gave them aspirin and Plavix.
For how long?
For 6 months.
6 months.
Yeah. Yes, please. No, it's the balloon. Yeah, because this is very friable tissue. It's really friable. Because think of it, this is from a burn, repeated
burning, yeah.
Repeated burning, so it's very friable, and that's where it just perfect. It's not the wire.
Yeah.
So I think it's just a tear of the wall. It's just, and that's where it happened.
And in some of these cases, we've seen a post-mortem case when we were in Cleveland.
Yeah.
That area is actually becomes almost like parchment-like.
Yeah.
I mean, with that repeated burning.
But it's a good thing to know that a covered stent is very helpful. And the reason why we do have these covered stents is because we do some coarctation of aortas for babies.
Yeah.
And when you do a coarctation of aorta, you can actually tear the aorta.
Yeah.
So you should always have a covered stent as your backup.
Very nice.
Thank you.
Good.